centers. Not quite sure what that means yet, but that's what they're going to do. We're going to have an independent payment advisory board. So MedPAC, which is really sort of a political organization, is going to be replaced. Actually, they're not going to be replaced. They'll still be in place, but this new payment advisory board will actually be the thumbs up or thumbs down committee for whether or not certain changes happen in the Medicare payments. We're going to have accountable care organizations. We know that these will be organizations that include doctors and hospitals and home care agencies and other things. We haven't really defined them yet, okay? But we do know that they are important, at least according to some people in Washington. Again, there's details behind each one of these in the appendix of my talk. And then we're going to have medical homes, and of course that's the primary care and care managers and other people who aren't connected today are going to all of a sudden magically become connected, and you can sign up at your local Medicare station to become a medical home. We're going to have all of these new payment systems, although as you look at the details behind each one of them, they all say, as determined by the HHS secretary. So the fact is, none of these payment systems or methods have been designed, defined, or in any way implemented. And finally, we're going to have reforms on hospital-acquired conditions. So basically, we're not only not going to get paid for giving somebody a ventilator-associated pneumonia, but we're actually going to be penalized. So that might actually be something that changes our behavior, right? Because if we start to get penalized for doing bad things to patients, maybe we'll think about how we might not do bad things to patients. So this is the core set of the delivery reform provisions. And most of it simply is not well defined yet or well enough defined yet to say this is how we need to act. But clearly, this is a huge, a huge undertaking to redesign, payment and other processes. This is just the timeline. So as the bill stands right now, in 2011, there'll be the federal Medicaid payments for hospital-acquired conditions will start. The deadline for the Innovation Center is January of 2011. So if you're going to be an Innovation Center, you need to apply for that this fall, and then those people will be chosen January. By 2012, then, you have to decide whether you're going to be an ACO or not, and the same thing for the deadline for whether you're going to be a medical home or not. By 2013, these different types of payment systems start to kick in, and the penalties start to kick in. And the Payment Advisory Board happens in 2014, and you can read the rest of that. So this is the timeline. It remains to be seen whether any of this will actually, well, we know the stuff in 2011 and 2012 will most likely happen. Whether or not the other things happen, we'll see. It'll be a political issue. So those of you who believe that all of these government changes controlled by government are good, I want to show you a little bit of Uncle Sam's track record on these sorts of things. So let's start with Barney Frank. Freddie Mac and Fannie Mae are fundamentally sound, 2008. How about Mr. Bernanke? I don't anticipate any serious problems among the large internationally active banks, February 28, 2008. CBO's estimate of the cost of Medicare Part D was off by 40%. The original 2010 projection for CHIP was $5.7 billion. It's now $12.6 billion. And Phil Ellis of the CBO, the numbers are almost certainly wrong. So, it doesn't give us a lot of hope here, folks, that what's been proposed and what's been legislated, is actually going to happen the way it's been suggested it's going to happen. So the point is, I guess, as Winston Churchill said so eloquently, you can count on Americans to do the right thing after we've tried everything else. What's interesting, if we start to think back to our problem again, we actually have a pretty good antecedent to what this health care reform bill is attempted to do. In the plan in Massachusetts, those of you from Massachusetts know the details of this, but maybe what we should have done is tried to take a look at what's actually happened in Massachusetts. So let's walk through what's happened there. Since 2006, when their health care insurance bill was passed, the cost is twice the original estimate and growing faster than the general growth in the United States, which I already showed you was on an exponential curve. So the state has a $5.5 billion deficit. A third of that is dedicated to Medicaid. 35% of the family practitioners are not taking new patients. And there's a significant overuse of the ED. 61% of the patients rate their income, or physicians rate their income uncompetitive. Hospital operating margins are trending down, and the current fee-for-service system is broken. So the Massachusetts Payment Commission has decided that we are going to move to a bundled, that they are going to move to a bundled payment as soon as possible, although it has not been tested and there's no pilots in place. So, what are the core components of the problem? Because clearly, you know, the problem that's been solved for at this point isn't the right problem. So these are the core components that we believe at the center are kind of at the crux of everything that's going on here. First, payment systems are broken. We know that. They're broken because they don't reward us, providers, for delivering better value. There is total lack of transparency of performance. So we really don't know how many medication errors your hospital had yesterday. You know, I contend that if I knew how many medication errors your hospital had yesterday and I knew your competitor's medication error rate, that might have a significant impact on where I went to have my care. We have no clue. We talk a little bit about the black box. Providers lack a consistent methodology for care improvement, and this is, of course, what we've all been working on for years, is that consistent methodology. So let's take each one of those core components of the problem and see if we can understand it a little bit more clearly as to what it is that we might want to do. So one of the biggest issue, these slides come from my friend Harold Miller at the Pittsburgh Regional Health Initiative. Harold has done some of the best work on payment reform in this country, and he's published several books on it, and I would highly recommend Harold to you as someone that really can help you understand. So the question is, how do we actually reduce healthcare costs without rationing? Because, you know, we've identified that the problem is that the rate of increase of costs is unsustainable. So let's just walk through this. Reducing costs without rationing. So if we had a healthy person and we were able to keep them healthy, that would be a good thing, right? If we had a healthy person and we had a preventable condition, we'd want to not hospitalize them, right? That would keep the costs down. And so we want a healthy consumer, continued health, no hospitalization, and if we do have to have a hospitalization, we want to have it as efficient, an efficient positive outcome. So here's what our current payment system actually supports. Okay? That we create a preventable condition, that we have an acute care episode, that we have high-cost successful outcomes, and that we have lots of complications. So that's how we get paid today. So the question is, what do we need to do so that we might actually align the payment system with what we want to see happen? So there's a couple different ways that Harold discusses this. One is an episode payment. So what we do is we say, if you're going to have an episode, that we're going to put it all into one, bundle. And so we're going to pay everybody together, the doctors, the hospitals, the home care agency, everything. So a single payment for all care that's needed from all providers, so that we start to reduce a little bit of the waste in the system and start to streamline. Now the problem with episode payments is that, how do you prevent unnecessary episodes? Because this really still doesn't get at the, paying for outcomes rather than paying for volume. So Harold takes this one step further and talks about this comprehensive care payment. And I think, as I scan what's going on in the country, both with payment reform initiatives, because we have one going in Wisconsin. There are payment reform initiatives in Minnesota and Massachusetts and Oregon and Washington. It appears that this is where we're headed. Now, I'm not suggesting that we're going to turn a light on tomorrow and all of us are going to get paid like the Massachusetts Payment Commission says we're going to get paid. But the comprehensive care payment or global payment for an entire patient journey is really is where we're most likely headed. So it's a single payment for all care needed for a condition. So is this capitation? So many of us lived through the 1990s, and as Harold would suggest, this type of payment system is really different than what we experienced in the 1990s. So the worst versions of capitation, there's no additional revenue for taking sicker patients. So in the comprehensive care payment process, what we're suggesting is payment levels are adjusted based on patient conditions. So the illness burden and other things are taken into account. Providers in the old world of full capitation would lose money on unusually expensive cases. In this comprehensive care payment model, there's limits on the risk that providers can accept for unpredictable events. In the old 1990s capitation model, providers are paid regardless of the quality of care. In the new model, bonus and penalties are based on quality measurement. And providers make more money if patients stay well. That stays the same. So as a global payment system, what we're trying to do is keep the patients well, keep them out of the hospital. And then flexibility to deliver highest value services remains the same. So we believe that this move to a comprehensive care payment model is where the industry is going. And so the question is, what is it that we need to do differently in order to skate to where the puck's going to be, as Mr. Gretzky so eloquently stated. So the other component of this problem is transparency. And there are some pretty interesting experiments going on throughout the country. I'm just going to talk about the ones in Wisconsin because those are the ones I'm most familiar with. Here is 161,000 diabetics in Wisconsin, and they are being reported. This is the A1C blood sugar control level. They're being reported by physician group across the state. So you can actually rank these physician groups on how well they actually manage diabetic care in Wisconsin. So Marshfield Clinic, Theta Care, University of Wisconsin, all of those clinics are actually compared against each other in this database. So patients can go in, look at heart disease, diabetes, preventative care measures, and actually rank the clinics in their market as to who is taking care of those particular problems most effectively. Same thing for hospitals. This is a hospital chart. On the horizontal axis is actually cost, and on the vertical axis is quality. The AMI means acute myocardial infarction. And so then we've plotted hospital performance on, these are the 6 process indicators for heart attack on that vertical axis. So you can see the quality performance, and then, actually if you go on this website, wchq.org, when you put the mouse on the individual dot, it tells you what hospital R is or hospital M is. So we're starting to see this kind of quality cost performance metrics, and as you can see, on the cost side, there's about 200% variation, right? Which is quite interesting. On the quality side, not quite as much variation, but on the cost side, there's 2.5 times difference from the lowest cost hospital to the highest cost hospital. So employers are actually starting to use this data. Patients are not using this data. We actually know how many people hit this website, and 97% of the people that hit this website or visit this website are either insurance companies, employers, or providers. So the providers are actually looking at themselves compared to the others. This is the next generation of data that we'll be releasing in Wisconsin soon. This is called an episode treatment group report. And on the top there, you'll see this is just a mock-up of the data, Generic Family Medicine Clinic of Wisconsin. You can see an overall cost index there, so you want to be below 1 on the cost index. And then on the right-hand side, you see the overall quality index, and you want to be above 1. So in this case, this clinic actually is lower cost and higher quality, and then you can drill down into the individual specific episodes. So in this case, preventative episodes, immunization, screenings. It gives you the number of episodes, it tells you the cost that you are generating, and then your peers' cost. Almost all of the brokers and insurance